Hello everyone. Thank you for attending our Baby's First Test webinar, Connecting the Dots Through Newborn Screening. Today's webinar will highlight how the NICU at Bonheur Children's Hospital and the Department of Pediatrics and the Division of Medical Genetics at the University of Tennessee Health Science Center developed and disseminated innovative newborn screening education modules for NICU nurses and patients. All participants are muted. If you have questions anytime throughout the webinar, please type them into the questions section on your webinar panel. Presenters will answer these questions at the end of their presentations. To provide some background on our presenters, Dr. Stacy Hines-Dowell is the principal investigator for the project and has more than 8 years of experience with clinical genetics. She holds a key role in organizing and facilitating the newborn screening process for Bonheur. She initiated the 2009-2010 pilot study and in 2012 developed the Newborn Screening 101 Provider Pocket Guide. In 2012, she also served as a member of the Baby's First Test Consumer Task Force. Dr. Jewel C. Ward is Professor of Pediatrics at the University of Tennessee Health Science Center and is Division Chief of Medical Genetics at the University of Tennessee Health Science Center and University Bonheur Pediatric Specialist. She is one of 3 active clinical geneticists specializing in inborn errors of metabolism. She has been and continues to be a member of the Tennessee State Genetics Advisory Committee, the primary committee for determining Tennessee newborn screening policies. She has actively worked and participated in connecting the dots since its inception. Julie Vonson has been working at Bonheur since 1995 as a staff nurse in the Special Care Unit, which is part of Neonatal Services. In her current position as Neonatal Services Coordinator for the NICU, she oversees discharge coordination for the NICU. We will now begin our presentation with Dr. Jewel Ward.
Good afternoon or good morning, depending on where you are. This is Dr. Ward. I'm very delighted to be able to talk to you today. Excuse me, I'm not advancing. Many of you may not have seen this cover of Discover magazine, but this was published in July of 2003, approximately 10 years ago. And it was just about the time that expanded newborn screening was beginning. And as you can see, the headline was, "Now the genetic testing really begins." It starts with a single drop of blood taken from each newborn, and then it goes a little astray and ends when scientists predict everyone's physical and mental future. I think it's a bit overreaching for the last part, but it certainly meant that it was now in the lay public's view. Now, I apologize for this slide, but it's hard to get 50 years of newborn screening in one slide, but I managed to do it, so let me take you through it. We're celebrating 50 years of newborn screening, and as you notice up here, in 1963, which would be 50 years ago, Dr. Mary Ephron at Mass General Hospital is credited with developing the techniques for mass screening methods for newborn screening. But she stood on the shoulders of some very important people. Before her, in 1961, Dr. Robert Guthrie in Buffalo developed a simple and inexpensive test for phenylketonuria, or PKU. And he stood on the shoulders of 2 other people at a minimum. Dr. Fehrling, who described PKU in 1934, and Dr. Beckel in Europe, who described the treatment for PKU. All of these things were necessary before Dr. Mary Ephron was able to go for mass screening. The reason that this was screened is that these children and these individuals did not succumb to their disorder but had mental retardation. And the diet intervened and prevented that. So it was the basis for starting newborn screening to detect them before clinical signs became evident. It was almost 10 years before the same type of test was developed for congenital hypothyroidism, another condition that may cause retardation, and that with intervention can be helped and therefore qualified for newborn screening. The same year, newborn screening became available for the hemoglobin disorders such as sickle cell, again by someone in Buffalo where Dr. Guthrie was. And then slowly then the information became available that it was appropriate to screen for sickle cell early because they could have a decrease in morbidity with early detection. Congenital adrenal hyperplasia followed in 1977. It's interesting that in 1982, Colorado was the first state to screen for cystic fibrosis, very much ahead of their time. 1984, biotinidase deficiency was able to be screened. Dr. Wolf, then at Richmond, developed that test. And then, as you notice, in 1993, there was a big shift, a paradigm shift in newborn screening, with 3 individuals, David Millington, Drs. Donald Chase, and Ed Naylor, all participated in contributing to this area of developing what was then a research instrumentation, tandem mass spectrometry, to be able to use this for newborn screening and further to encourage the design of instruments that could be used in state laboratories. In 1990, Hawaii became the first state to enact uniform newborn hearing screening. And then in 2005, the Secretary's Advisory Committee, which was composed of individuals from the American College of Medical Genetics, as well as individuals from the HRSA agency, had been working to try to put some sanity to the newborn screening panels. Up to this time, it had been up to each individual state to decide what to screen and when. They made their endorsement of 29 conditions that they thought all states ought to be screening. They recommended in 2010 the addition of severe combined immunodeficiency disease, and in 2012 added critical congenital heart disease. This all is beautifully described in a publication from the Association of Public Health Laboratories that was headlined at their meeting this year, and I shamelessly take their information. Tennessee parallels this, and I'll just briefly take you through, because no matter what state you're from, you should kind of know how your state applied and paralleled those national trends. Obviously in the late 60s, PKU did hemoglobinopathies and hypothyroidism in the 80s, added galactosemia in 1992. Hearing screening was voluntary in 2001, but in 2008 in our state, it became mandated. We added biotinidase in 2003, but then in 2004, the tandem mass spec-based tests were added. And the reason this was a paradigm shift is now you can screen for several categories of disorders: organic acids, fatty acid oxidation defects, and amino acid disorders. All can be done on one instrumentation. There are ethical issues that each state has had to deal with tandem mass spec-based disorders, but we are dealing with it. 2008, cystic fibrosis was added. In 2013, we added the congenital heart disease screening. SCID is pending the instrumentation for implementing that here. And this is a cartoon for the tandem mass spec. You know, when you say tandem mass spec, it sounds very researchy, and it really is a couple of instruments that can be summarized as follows. Here is a picture of a newborn screening card, which many of you have probably seen. There are small punches taken out of this card. These are added to wells, which are placed in a tray that will have an automated system that will then inject it into the first mass spectrometer. That will separate analytes, and then here they are bombarded and broken into fragments and go through another analysis, which then is detected on a computer, and there's a readout, and you see if the amount is the appropriate amount and whether it's a normal or outside the range. That's tandem mass spec, and that's what has increased the expanded screening so much in the last few years. Each of you is probably from a different state, and you probably ought to know something about the demographics of your state. And this is the demographics for Tennessee. Don't expect you to memorize that, but you should kind of know the population, what your border states are, what your metro areas are, how many counties do you have, and that translates to how many health departments you have in those counties that are having to help follow up the positive newborn screens. We call them presumed positives here in Tennessee. Our birth rate in Tennessee is about 85,000, and our racial component currently is about 75% Caucasians, a little over 20% African Americans, and 3% of other ethnic groups, other racial groups, and then Hispanic is approaching 10% currently. And this is a picture of our state. It's one of the challenges we have with it being a very long state. It used to be back when I came here to UT in the late 70s that here we are over here in the lower left corner where Memphis is, but we were taking care of PKU patients from the whole state. Now we have 3 metabolic centers, one at UT Knoxville here in Knox County, one at Vanderbilt here in Davidson County in Middle Tennessee at Vanderbilt, and then Shelby County. And these are our counties that we are all responsible for the follow-up of newborn screening. The other thing you should know about your state is how it's organized to help deliver the newborn screening services. And in ours, the Department of Health at the state of Tennessee has laboratory services and maternal and child health programs. Each of these contributes to the newborn screening. The laboratory, of course, performs, in addition to other things that we associate with state newborn screening laboratories, they perform all the tests related to newborn screening. The program for maternal and child health administers infants and children and adolescents programs, which include newborn screening, follow-up program. It is responsible for the Genetics Advisory Committee, which I'll go into a little bit more detail about, handles the newborn hearing screening, and is handling the data from the congenital heart disease screening. The Genetics Advisory Committee, and we apparently were ahead of our time, was actually established in the 70s. So the genetic centers in the state had been talking with each other for many years before the newborn screening expansion hit. We are advisory to the genetics and newborn screening section of the maternal and child health and the laboratory. So we help combine these two and advise both on both the laboratory services as well as how to handle follow-up. The representatives are from the comprehensive genetic centers in the 3 grand areas in Middle, East, and West Tennessee, as well as 3 other satellite genetic centers in the state. Then we have our hematology, endocrine, pulmonary, and cardiology colleagues that also are part of this panel as well. We also have consumer representation, which is important for keeping the ethics and consumer interests involved. Our GAC function is to advise, to provide education to healthcare providers and consumers, to provide outreach to communities, to maintain data on genetic disorders, and to make advice about the newborn screening panel components in the state of Tennessee. You also might have in your state a website for newborn screening, and this is the URL for our website in Tennessee. You can get there by just Googling Tennessee, newborn screening, and it will take you to this website now. The site has parent information, a pamphlet link that can be printed out, a provider information, a pamphlet link. There's information on the disorders, one for parents, one for providers. There's information for the hospitals and providers, including blood collection, how to do hearing screening, how to do the critical congenital heart disease screening, and also is the unsatisfactory rate of specimens received for that hospital. There's a secure remote viewer that they have just provided now that's online for being able to obtain results for newborn screening to providers in the state who sign up and have a password. There's a quarterly newsletter, and there's resource links that they have, especially to the American College of Medical Genetics ACT sheets for the different disorders, as well as the American Academy of Pediatrics. So if your state has a website, I encourage you to become familiar with it. This is one of the DVDs that the state newborn screening program has done that is circulated to hospitals and the people who obtain the blood so that nurses and laboratorians and lab technicians can view exactly how to obtain this, and there's also information on the disorders. This was provided free to the hospitals for their education purposes. Now, one of the problems that has come up with newborn screening has been unsatisfactory rates. The state deals with unsatisfactory rates from hospitals. And one of the problems that the unsatisfactory specimens can result in is that there's possible misdiagnoses, there may be delay in diagnoses, and this is going to cause additional expense in having to repeat these specimens. An unsatisfactory definition, currently the state defines on their site, there's 20 reasons for the rejection of a specimen. If they can at all possible, they run them and try to get some result, but they can't officially report them out, and they have to say it's an unsatisfactory, and the recommendation generally is to repeat. So you can see that there could be a possibility of a delay in the diagnosis and getting a child in for follow-up if this happens. So they've been trying to decrease the unsatisfactories. The sources have come from hospitals, from health departments, and from primary care providers. So there's no one series or no one category of individuals that are providing these. They have tried educational opportunities, working with hospitals, visiting with hospitals to find out what might be some sources of problems. The instructional video that I just mentioned they have provided. However, the on-site education is becoming more difficult to do with shrinking dollars. And the county health departments are having difficulty as well because they have lower numbers of people to be able to provide this education. So all the genetic and specialty centers are encouraged to provide more education to both hospitals, health departments, and providers. In that regard, we have tried to increase educational efforts here to providers, to health departments, and to hospitals to further educate them about the expanded newborn screening and how critical it is to have these analytic specimens obtained appropriately. In this regard, nurses are the primary patient caretaker in the hospitals, in the public health departments, and in the provider sites. However, nurses' academic training gets less information about newborn screening, the advances in newborn screening, and the importance of newborn screening. Therefore, it becomes important for the nurses to be trained on site as they are delivering their services. In that regard, then Stacy Hines-Dowell has developed modules and taken on project of trying to increase the education of nurses in Bonheur, which is a tertiary hospital, not a birthing hospital, but a tertiary hospital, because there are then challenges that are unique to being a tertiary center. So I will now turn this over to Stacy.
It all started with an ideal. In 2009, Connecting the Dots was born. So the question is, what is Connecting the Dots? Connecting the Dots is an educational curriculum for neonatal intensive care nurses in a tertiary hospital. In 2009 to 2010, we conducted a pilot study. The goal of the study was to develop and implement a curriculum addressing nurses' knowledge and barriers regarding newborn screening. The second goal was for participants to gain a better understanding of the general procedures, laws, and goals of Tennessee's newborn screening guidelines. The pilot study focused on designing a standardized clinical educational module for Bonheur's neonatal nurses. We used a quasi-experimental design, pre- and post-test comparison, which measured the participants' mastery of the material as well as their attitudes toward the subject matter. The participants were recruited through a convenience sampling method, which both the participation was voluntary and anonymous. We had a total of 26 full-time and part-time RNs from our NICU and infant care units who took the pre-test. Then the participants accessed the PowerPoint educational module, which was developed, and it was put on our CHECS web, which is our institutional online educational informatics system. So the results showed a statistically significant difference of the 26 participants' pre- and post-test results. Of the 26 participants, 22 scored better on the post-test 3 scored the same on both tests, and 1 scored lower on the post test. So what did we learn? We learned that 85% of the participants showed an increase in knowledge, suggesting the value of entering into phase 2 of this project. Now, let's fast forward to 2013. Our application was selected as one of the 2013 Baby First Test Challenge Awards. Yay! So I had 3 deliverables in the phase 2 of Connecting the Dots, which was to continue to develop and update the educational curriculum that was developed in 2009, to develop an educational materials for NICU parents in addition, and also to have a webinar. And here we are today. So we had a very strategic plan in mind when we started the project, we met with multiple people, multiple groups in our hospitals, leadership, management, from our NICU leadership, from our CNO of the hospital to our directors in the laboratory, who all play an intricate part in the newborn screening process at our hospital. We conducted a focus group with 25 NICU nurses. And we got really good feedback from this focus group. The nurses were very excited about starting up phase 2. We had a mixture of some of the nurses who participated in 2009, and then we had newer nurses who were just coming out of orientation who were eager to learn more about newborn screening. And we also refined the educational module from the information we gathered from that focus group. We kind of gave a presentation to them, going over the materials that we would discuss, and kind of got their feedback on what did they feel about the material. Was it useful? Was it too much? Did we need more in-depth baseline educational things about newborn screening? So they gave us a good idea on what we needed to focus on for them to know what they needed to know in order to take care of their patients. We also started outlining drafts for our parent educational storyboard. We hired a graphic designer who worked with us diligently to put together a beautiful storyboard, and I will show that at the end of this presentation. The goal of was to use a quasi-experimental pre-post test design as we did in 2009. But from the information, from the different meetings we had a change in plan, which was a good thing, because once we got administration and the NICU leadership involved, they took this and ran with the idea, and what they ended up doing was making this module one of the annual competencies for the nurses, which meant that they all were given this, were required to take this test. So it was difficult because of logistical things. The way our informatics system works to check well, if you give the pre-test and then the person takes the pre-test, then they had no way of navigating straight to the educational module, then to the post-test. So we had a limitation there. So with 120 nurses, it would have been a logistical nightmare. So what we decided to do was just to give the post-test after the educational module. So instead of having pre- or post-test results, we only did post-test. And for our parents' educational storyboard, we did do a pre- or post-test because we had a smaller number of parents recruited. So our goal was to recruit 50 NICU nurses, and that's what I'm going to report on, 50 NICU nurses. But to this point, we've had 100 nurses to actually take and complete the educational module. And we also recruited 20 parents from our NICU. The results. The nurses were given a 10-question post-test. 82% answered 9 of the 10 questions correctly. 40% failed to answer 1 question correctly. And I think that's important to talk about. That means that we may have had a question that may need to be reworded or maybe need to be replaced. And then we also had 90% of the NICU nurses told that the educational module was informative. So that was really good. We had really good feedback and really good reception of this module. For our parents, the parents were given a 5-question pretest. As you can see, there were parents, they were recruited as they entered into the ICU. We let them know what we were doing, what our project was about, and we'd have parents to volunteer on the spot. And when we got like 1 to 3 persons there, parents there, we would do it like in a group format. So the storyboard presentation was given to all the parents, like I said, either in a small group or individually, and then the parents were given the same 5 questions following the presentation. So for the pretest, 100% of the parent survey responded with 3 or more questions incorrectly. On the post-test, after they had the storyboard presentation, 85% of the parents answered each question correctly. The 5th question asked, is this your first baby? 9 of the parents answered yes, and 11 answered no, which is important. This is important because 11 majority of the parents were brand new parents, and this will probably be the first time that they've heard about newborn screening. So that was really good. So overall, there was a statistically significant improvement in knowledge amongst the parents after the storyboard presentation. So in conclusion, effective newborn screening testing in NICUs can significantly reduce long-term disability or even death in an affected child. This validates the importance of an evidence-based, standardized, comprehensive educational module specific to NICU nursing. And what we've learned is if you educate the nurse at the bedside, they're going to educate the parents to be an effective member of our team. As we focus on family-centered care, the parents play an intricate role in their child's treatment plan. And having both the parents and the nurses and all the staff together to have the information and the tools they need, it makes the perfect marriage for the team system that we're trying to develop. Special thanks. I want to thank Babies First Test and Genetic Alliance for giving us this opportunity. Without your help and support, we wouldn't have been able to accomplish this. We're so excited. Bonheur has taken this project and really taken it under its wing, and our goal is to implement it in one of our sister birthing facilities. We're really excited about that, so thank you so much, Babies First Test and Genetic Alliance. I would like to thank Dr. Jewel Ward and our entire ULPS Division of Medical Genetics for your time, your consultation, your help with all of this. And I can't leave out my Connect and Adopt team who suffered with me and stayed up late nights working on trying to get these modules together. I really, really, really appreciate the NICU nursing staff who really was eager to learn, who embraced this project, and who's excited to continue to move the efforts forward, and also with leadership in our nursing administration for helping to make this an annual competency for all the nurses in NICU. And hopefully throughout the hospital, maybe every nurse in each unit, this will be part of their annual competency. So thank you, Bonheur's Nursing Administration. And last but definitely not least, I would like to thank the Tennessee State Newborn Screening Lab for your expertise and your consultation on all of the materials we developed. We appreciate you, and we thank you so much, and we hope to continue to build our relationship and our tools that can be used throughout the state of Tennessee. Thank you. I did want to show you all the pocket guide, the parent pocket guide, which was created. And this is, we actually had it in a storyboard format. If you remember in one of the pictures, the young lady was holding like a flip chart. So once we did the presentation with the parents, we also gave them a small pocket-sized guide of the parents' pocket guide to newborn screening. And if you could see the little black mark, those indicate like a spiral booklet. So we thought it was important to just show really good graphics of, each part of the newborn screening process. You have the hill stick, and how it goes in the mail to the state lab, how the results are reviewed. Then you have part 2, the CCHD, critical congenital heart, which is important, so they understand and kind of get a visual of what it is. And then the third part being the hearing screen. And to stress that newborn screening is for all babies. And the next thing I want to show you all is the educational module for the nurses that we created. It's a total of about 50 slides, 49, 50 slides. And what we did is kind of laid the foundation of, we laid the foundation of, what is newborn screening, and then kind of talked about the evolution of why it's important, and then talked about the 3 different components. We kind of mirrored it to what we created for the parents. We broke it up into the blood spot hearing and the pulse oximetry testing. So here's an example of when we talk about the metabolic and genetic disorders from the Hill stick. And also to give the nurses a visual of what the actual filter paper, what it looked like, and what's important to complete on the filter paper card. And then just a little animation of the system where it's actually, and Dr. Ward actually showed this in her presentation as well, just the example of how it goes from the Hill stick to the filter paper to the state lab, and it goes through this mass spec machine, and then the results are computerized and given to the healthcare provider to share with the parents. And I'm going to just skip to the hearing screening part. And what we did for the nurses to know that they're still in the section of hearing screen, we used little ear animations at the top to let them know that they were still within the hearing section of the educational module. So that concludes my presentation. Thank you so much for participating and hearing our journey with Connecting the Dots. Thank you.
Great. Thank you to our presenters for their excellent presentation today. I apologize for the technical difficulties, but we will have this presentation, this webinar, on our website, www.babiesfirsttest.org. And there you'll be able to view other webinars as well as upcoming webinars that we'll be hosting. So this is the end of our webinar. So thank you for attending and have a great day.